As cataract surgeons, we'd like to hit the bullseye every time we operate. The holy grail for us is a post-op vision of plano 6/6. With the advent of newer technology and devices, we are able to obtain more precise, more accurate biometric measurements and newer biometric parameters which may be called for in some of the new IOL formulas. The newer formulas or the formula upgrades and newer concepts, we have come a long way. However, we must realize that this is a very dynamic, very happening field, and a lot of new concepts, new practices are being introduced on a very rapid frequency, so that we need to be on our toes all the time. In my presentation today, based on the preferred practice pattern theme, I would like to share with you my current thoughts or concepts on fine-tuning refractive IOL outcomes, and I would like to thank Karnataka Ophthalmic Society and Dr. Elan for giving me this platform. I would like to start by saying that there has to be a paradigm shift in the way we view IOL power calculations. It is no longer a one-off event in the life of a cataract patient. Rather, it should be viewed as a process, a method, or a system which transcends the preoperative, intraoperative, as well as the postoperative period. Preoperatively, I would like to have a detailed examination of the patient and know about the sources of vision loss and factors that could influence the accuracy of IOL calculations. I would like to know the degree of nuclear sclerosis and the degree of posterior subcapsular cataract. I would also be interested in knowing whether this particular eye falls in the extremes in terms of very short axial length or a long axial length, whether the patient has got posterior staphyloma, how is the fixation pattern of this patient, so on and so forth. I would also be very keen to study the ocular surface of every patient that undergoes biometry, because it is well known for the last couple of years that a suboptimal ocular surface may not only adversely impact the toric IOL calculations but also non-toric calculations. So every patient lined up for biometry undergoes an ocular surface workup, and if it is found deficient, is put on appropriate therapy. Patient is called back after 4 to 6 weeks to repeat the biometry, and it may have to be repeated twice or thrice just to ensure that the ocular surface has been optimized and the biometric values are all reproducible. Another factor that has to be kept in the mind is the sequence of the biometric evaluation as you work up the cataract patient in the course of the day. We would like to perform all the evaluation on a very pristine or a virgin cornea before we have instilled any eye drops or before the patient has undergone any contact examination like Goldmann applanation tonometry or gonioscopy. Patient counseling is also very, very important, because we need to know what exactly is the patient's visual requirement and the lifestyle. For example, we may be able to give a patient an uncorrected vision of 6/6 with +3 add N6, but he may be very happy he may be very unhappy if he has been a myope throughout his life and is a voracious reader. So we need to know what exactly are the patient's lifestyle requirements in terms of visual needs, and select an intraocular lens design as well as power based upon the outcome of the patient counseling. I always perform the biometric measurements with multiple devices, at least the axial length. The intraocular lens power calculation is also done using multiple formulas. And after the entire exercise has been gone through, I would select an appropriate intraocular lens of the desired power for the given patient. For toric IOL, in addition to performing an automated keratometry, I also perform an optical biometry, a topography, and eye trace. I depend upon the IOL master for the magnitude of the astigmatism and topography for the axis of the astigmatism. And it is also important to remove the contact lens prior to the keratometry. If it is a hard contact lens, make sure that it goes off 2 weeks before the biometric evaluation. There is a strict set of validation guidelines for the biometric measurements that are obtained. This chart is put up in my biometry room. So whenever the optometrist encounters an odd biometric parameter as is given in this chart, that particular reading is deleted and a fresh reading is obtained. I believe that it is very important to spend more time doing the biometric workup, more chair time talking to the patient at this stage to avoid the refractive surprises. Because if you have a refractive surprise, which can be definitely avoided by adhering to proper validation guidelines, you need to be spending a lot of additional chair time in the post-operative period and trying to talk to the patient as to what happened and what would be the remedial measures. So validation guidelines to be followed for biometric evaluation. Now, what do we do for hard cataracts? Optical biometers work extremely well for the routine cataracts and for the very hard cataracts, but for a few swept source OCT based biometers which may not be available with most of the surgeons, ophthalmic surgeons, how do we tackle these cases? For example, an advanced cataract like this. So I look at the fellow eye in these cases, and if the fellow eye has an immature cataract which is amenable to optical biometry, or it's a pseudophakic eye, that is more or less a clear visual axis, relatively clear visual axis, I follow this strategy. After performing the optical biometry for the fellow eye, I have the ultrasound biometry done for both eyes. Now, if the axial length by both these biometric techniques is more or less the same for the fellow eye, I assume that the ultrasound biometry has been done properly for the eye to be operated. Now, if these two values are different for the fellow eye, I would like to repeat the same sequence of tests for confirmation. So this definitely has helped me a lot in getting good refractive outcome for patients with hard cataract. One thing must be remembered, that if we use an ultrasonic axial length in the IOL master to calculate the intraocular lens power, we must use the ultrasound lens constant, not the optical A constant. And this particular chart, see, every lens has got A constant for the ultrasound and for the optical biometric technique. So this chart is put up on my biometry wall, and an appropriate lens constant has to be used for biometry in these hard cataract or complex cataract situations. I mentioned at the outset that I use multiple formulas. Let me give an example. This is a post-ICL cataract in a patient with high myopia. So biometry and IOL power calculations are a little tricky in patients with very long axial length. I'm not going into the details, which is beyond the scope of this discussion. But after the biometry was over, and when I optimized the axial length using the Wang-Koch equation, I found out that all the formulas, the SRK-T, Holliday, Hygie's, Hoffer-Q, are suggesting a lens of 3 diopter. I use Barrett Universal 2 for all my patients, and in this particular case, Barrett Universal 2 suggested a sensor lens of 2 diopter. So I went by the majority decision and implanted a +3 diopter sensor lens, and post-op results were very good, and I was happy that I followed the majority's opinion. So basically, it is always nice to use multiple formulas, two different types of formulas, before you finalize the intraocular lens power for a given patient. The intraoperative period is also very, very important. Most of us now perform a standard cataract surgery, temporal clear corneal approach, 2.2 to 2.8 millimeter incision, and a rhexis which is 5 millimeters in size. The lens is implanted within the capsular bag so that there is a 1 millimeter overlap on of the anterior capsular overlap on the optic. So this basically gives us a proper effective lens position, and this definitely helps us a great deal in hitting the target refraction. In certain situations where we have encountered a zonular weakness, zonular damage, or a posterior capsular rent, and implanted a lens in a different location, we may have to tinker with the intraocular lens power, which is again beyond the scope of the discussion today. Intraoperative aberrometry is being talked about. There are a lot of publications in the literature, but in a recent webinar that I had conducted, Dr. Douglas Koch had mentioned that once our preoperative biometric measurements become much more accurate than what it is now, intraoperative aberrometry will no longer be required in our day-to-day practice. The guidance systems for toric, for orienting the toric IOLs also do pretty well. Postoperatively is the moment of truth. Here you realize how well you have performed. So you assess the refractive and anatomic outcome of your cataract IOL surgery. And if you have a refractive surprise for whatever reason, you should be able to perform the remedial surgeries like IOL rotation, exchange, piggyback intraocular lenses, or corneal refractive surgery. And if the residual refractive error calls for adjustment of the A constant, that also has to be done, and I'll be talking more about it in a while from now. I also inform my patient that in spite of our best efforts in getting the optical biometry values using advanced formulas, there are certain limiting factors. For example, the IOL power steps and the manufacturing tolerance that is approved by ISO and the ANSI, these standards. The intraocular lens do not come, rather they come in steps of 0.5. We do not have the exact power of the lens printed on the lens box. And as regards the manufacturing tolerance, ISO definitely allows some amount of inaccuracies. For example, if we are looking for a 30 diopter intraocular lens, the lens could be 29 or 31 diopters. So because of non-availability of the exact intraocular lens power and these manufacturing tolerance permitted by the standardizing by organizations, there is a limitations that still exist, and maybe because of that reason we still do not do as well as we should have been doing. This is the manufacturing tolerance for the toric intraocular lenses. The concept of lens constants is quite an important one, and earlier on we were routinely performing lens constant optimization for our cataract surgeries. But today almost all of us are performing cataract surgery in a very, very similar standardized manner, which I've already referred to in my talk earlier. And most of us employ formulas like Barrett Universal 2 or Hill RBF, which is again utilized by a large number of surgeons. There's a huge database. So the lens constants which are already incorporated in these formulas tend to be pretty accurate. Problem happens when I use a new type of lens which I have not used before and which are not present in these websites. In that situation, I would start off with a lens constant which is written on the box, and then depending upon the postoperative outcome for every 10 patients, I would change the A constant by a decimal of 0.1, either upwards or downwards. And in case the surgeon wants to optimize the lens constants, there are various ways it could be done, which are enumerated here. Examination length becomes important if you are performing refraction in a small room which is less than 4 meters in length. So use this particular formula to correct your spherical equivalent. So spherical equivalent refraction plus 1/6 minus 1 divided by test distance in meters. So what should be the ideal pupillary size at the time of biometry? This is a question that plagues us most of the time, because sometimes, though whatever I've said earlier, we do biometry with a pupil that is dilated. So recently there was a publication, in fact the middle of this year, which showed that for multivariable formulas like Barrett Universal 2, Olsen or Hill RBF, post-dilatation biometry measurement may yield a myopic surprise in a significant percentage of cases. For patients who have already got one eye operated, we can use the first eye prediction error to refine the refractive outcomes when we consider surgery in the second eye. So there has been a lot of literature publications on this topic, and this is what I follow in my practice. If the already operated eye has an error of more than 0.5 diopter, there is a great deal of interocular symmetry, and the second eye parameter is similar to that of the first eye. Transcription errors have been excluded, and there is no wrong IOL power that has been implanted. IOL malpositions like decentration, tilt has been ruled out. Then I use this adjustment coefficient. For Barrett Universal 2, I would use a coefficient of 0.3, and for the other formulas, I would use a coefficient of 0.5. In fact, one of the newer formulas, the Pearl DGS calculator, has got this additional feature called the second eye enhancer, where you put in the data pertaining to the second eye surgery for you to get a more accurate IOL power calculation in the fellow eye. New formulas have come up, and the Kane formula has been knocking at the doors for quite some time, since 2017. And last year and this year, I found a large number of publications in the peer-reviewed literature which has published information on the Kane formula. So these are some large studies showing the superiority of Kane formula in non-toric IOL situations. The Kane toric formula is again done extremely well in this particular study, published just last month. And even keratoconus formula by Kane has also done extremely well. So if you look at that particular formula, so you see you have a feature for the non-toric calculations, toric calculations, as well as keratoconus calculations. And then there is also a gender feature that is incorporated in this particular formula. The gender of the patient seems to have some sort of influence on the IOL formulas. For example, the Barrett Universal 2 formula has a lower mean absolute error for the males, and the remaining formulas for the females, the mean absolute error seem to be lower. The gender differences are more pronounced at extremes of axial length and anterior chamber depth, and some of the near formulas have this as a variable to be filled in while utilizing the formula. So the gender influence on IOL formula is something I'm going to watch in 2021. Friends, in summary, to get good results in IOL power calculation, use validated measurements, work with properly optimized lens constants, adapt to new technologies as they present, employ the right formula, and strive to use all available resources to their best advantage. Thank you so much for your patient hearing.